Look, if you break your arm, the diagnostic process is usually, well, it's incredibly satisfying, right?
Oh, absolutely. It's very straightforward.
Exactly. You go to the hospital, they take an x-ray, and you see that jagged white line right across the bone.
Yeah, it is completely binary. It's broken or it's not.
Right. But if you were to walk onto a university campus right now and ask, even a first-year medical student to define cerebral palsy in one sentence, you almost certainly get a response that sounds just as binary and clean.
Which is funny because well, it's really not.
No, not at all. But they'd likely say something along the lines of brain damage at birth causing spasticity.
Right, and it sounds perfectly logical on the surface. But relying on that one-liner is a massive trap.
A huge trap.
Yeah, it is dangerously incomplete. And for a medical student sitting for their clinical exams, answering with that phrase would cause some serious problems.
And that's why we are doing a deep dive today. We've got this fascinating clinical transcript between two medical professionals as our source material. And right out of the gate, we learned that this common definition fundamentally misunderstands the reality of the condition.
It really does. And that misunderstanding, it sort of ripples outward.
Yeah, because the language we use in medicine, it dictates not just how doctors treat patients, but how individuals understand their own bodies. And honestly, society as a whole views disability.
Exactly. So our mission today is to unpack what cerebral palsy actually is. We need to dismantle the myths surrounding it and explore why getting this medical language right is so crucial for everyone.
Right. If brain damage at birth causing spasticity is the wrong answer, we have to start by establishing the right one.
So the modern clinical definition describes cerebral palsy as a group of permanent disorders. These disorders affect the development of movement and posture, which then lead to limitations in activity.
Okay, let me pause you there. Because the critical mechanism underlying all of this, and our source makes this so clear, is that the disorder results from a disturbance in the developing fetal or infant brain.
Yes, the developing brain. That is the key.
Right, let's unpack this. Because the emphasis just has to be on the word developing. It is the crux of the entire diagnosis.
It changes everything. What's fascinating here is that the developmental stage of the brain dictates the fundamental nature of the disorder.
Meaning it's not just an injury to any brain.
Exactly. Cerebral palsy is absolutely not an injury occurring in an already mature nervous system.
Okay, so give me an example.
Well, consider a 30-year-old who gets into a severe car accident, right? And they sustain a traumatic brain injury that leaves them with severe muscle spasticity and mobility issues.
Right, they have a brain injury and they have movement limitations.
Exactly. But they do not have cerebral palsy.
Because the environment where that disturbance happened is completely different. The 30-year-old's brain was already finished?
Yes, the architecture was already there.
It makes me think of an analogy, like imagine a massive earthquake striking a city.
Okay, I like where this is going.
Right. So if that earthquake hits a fully constructed 50-story skyscraper, it's going to cause significant damage.
Sure. The drywall cracks, the windows shatter.
Exactly. Maybe some of the internal plumbing breaks. That is your mature brain injury. A fully established structure taking a major hit.
But the core architecture of that skyscraper was already finished before the earthquake hit.
Right.
Now, apply that same earthquake to a building that is actively under construction.
Oh, wow. Yeah.
Right. The concrete for the foundation is literally in the middle of being poured.
Huh.
The steel beams are just being hoisted into place, and the scaffolding is only half built.
And then the ground shakes violently right at that exact moment.
Yes.
So the building doesn't just sustain surface damage, its fundamental architecture, like the very way it continues to grow and take shape from that day forward, is permanently altered.
Precisely. The scaffolding set's crooked.
And then the future floors, they have to be built on top of a foundation that dried at a slant.
That captures the mechanism perfectly. When a fetal or infant brain experiences a disturbance, whether that's from a lack of oxygen, an infection, or some kind of vascular event, it is still actively pouring its foundation.
The connections are still forming.
Exactly. The neural pathways are actively trying to find their connections to the muscles. So the disturbance doesn't just break a system that was already functioning smoothly. It alters the developmental trajectory of movement and posture, literally from the ground up.
Which naturally leads to a major question, I think, about how doctors actually confirm this in the real world.
Oh, the diagnostic side of things.
Yeah, because if the timing of the injury is so specific, how do you diagnose it?
Right.
My immediate thought, just given modern technology, is that you just put the child in an MRI machine.
That's what most people assume.
Right, like if you see the old brain injury on the scan, isn't that case closed? You have the image, you have the proof, you give the diagnosis.
You would definitely think so, especially with how heavily modern medicine relies on imaging today.
Yeah, we scan everything.
We do. But our clinical source text stresses that a scan alone is never enough.
Wait, really?
Never. You cannot diagnose cerebral palsy simply because an MRI shows an old lesion or some kind of anomaly in the brain.
So what else do you need?
There must be a tangible, clinical, functional effect on the patient.
So a doctor is looking for a functional reality, not just a picture on a screen.
Exactly. And to navigate this, clinicians use a mental checklist.
Okay, let's go through it.
They look for 5 broad features to confirm the diagnosis. And it starts with the most obvious one. There must be a visible disorder involving movement, posture, or motor control.
Which makes sense, but this is where the umbrella nature of the condition starts to show, right? Because that movement disorder can look drastically different from person to person.
Oh, absolutely.
Right, because earlier we mentioned spasticity, which is that stiff, tight muscle tone most people associate with the condition. But the source text outlines several other ways this motor control issue can manifest.
Yeah, spasticity is the most common, but you might also see dystonia.
And that's the one with the involuntary movements.
Right. Dystonia involves involuntary muscle contractions that cause these repetitive or twisting movements. Or, a patient might present with ataxia.
Ataxia, that one is more about a lack of coordination and balance, right?
Exactly.
I'm picturing a child trying to reach for a cup on a table.
That's a great example.
Like, their muscles might be perfectly strong, but the timing of the signals is off. So their hand shakes or misses the target because the brain just struggles to coordinate the distance and the muscle firing.
That's exactly it. It's a functional example of ataxia.
Yeah.
The motor disorder has to be present, whatever form it takes.
Okay, so that's requirement 1. What's next?
Then we move to the second requirement. The origin of that motor disorder must be in the developing brain.
Right, going back to what we just talked about.
Yeah,
So that completely rolls out a whole host of other medical issues.
it does.
If a child has a movement disorder, a clinician has to ensure the problem isn't located in the spinal cord or the peripheral nerves or, a disease of the muscles themselves.
Like muscular dystrophy, for example.
Exactly. The origin has to strictly be the command center.
The brain is the sole origin point,
Oh,
yes.
okay, got it.
Then we hit the third requirement, which is honestly, arguably the most complex.
Oh.
The underlying brain disturbance must be non-progressive,
Non-progressive.
meaning the actual injury in the brain cannot be actively spreading or deteriorating.
I definitely want to circle back to that because that concept is completely counterintuitive to anyone who has actually spent time around this condition.
Oh, for sure. It trips up a lot of people.
But let's finish the diagnostic criteria first. So we have a motor disorder originating in the brain that is non-progressive.
Right. The fourth requirement anchors the diagnosis in reality, which is that the motor disorder must cause a meaningful functional limitation.
And this is why this matters so much for anyone listening who interacts with the healthcare system.
How so?
Well, this specific requirement prevents doctors from over-medicalizing harmless anomalies.
Yes, absolutely.
Imagine a kid who has a tiny incidental blip on a brain scan from a complicated birth. But at age 5, that child is running, jumping, playing, and moving without any meaningful limitation in their daily life.
Right. You don't label them with cerebral palsy just because of the scan.
Exactly. The diagnosis is strictly reserved for when the neurological difference actually impacts how a person lives and moves.
It protects the patient from an unnecessary label.
Which is huge.
And finally, the fifth feature is that the condition is persistent and generally lifelong. It is not a temporary delay that a child simply outgrows.
Okay, so summarizing that checklist, a lifelong non-progressive brain disturbance that affects movement and causes functional limits.
You got it.
But, okay, I have to push back on that third point now.
The non-progressive part.
Yes.
Yeah.
I am genuinely confused by the insistence that this is a non-progressive condition.
It is the most common point of confusion, honestly, even among medical professionals in training.
Because anyone who knows a child with cerebral palsy knows that their physical condition can, and often does, change drastically over time.
It does, very much so.
You see kids who are relatively mobile as toddlers, But as they age into adolescence, they develop severe muscle contractures.
Yes.
Like their limbs might pull tightly inward, walking might become incredibly painful or entirely impossible. They might even require surgeries just to straighten their legs.
Right.
Their function is actively declining. How can the medical community look at a child losing their ability to walk and confidently call that non-progressive?
It is such a fair question, and it's the single most important nuance in this entire deep dive.
Okay.
The contradiction you are wrestling with is exactly why older medical terms like static encephalopathy were retired.
Oh, because the word static is confusing.
Right, they were incredibly misleading to parents and patients.
Because static implies that nothing changes, you get the diagnosis, and that's your baseline forever.
But we have to conceptually separate the brain from the physical body it controls.
Okay, separate the brain and the body.
Yes. The underlying brain lesion, the original disturbance that happened during fetal development or infancy, is indeed non-progressive.
Meaning the damage is done and it stops.
Exactly.
Yeah.
The damaged area of the brain is not expanding. It is not continuously worsening, spreading, or eating away at healthy tissue.
Okay.
But the clinical presentation, the way that brain injury physically manifests in the body, that is highly dynamic.
Here's where it gets really interesting, because I was trying to visualize how something static causes a dynamic problem.
It's hard to picture.
It is. Think of a shallow, quiet stream.
Okay.
Someone drops a large, heavy rock right in the middle of it. That rock represents the static brain lesion. It's heavy, it's sunk deep into the mud, it never grows, it never shrinks, and it doesn't move downriver. It is entirely non-progressive.
I like this. But the environment around the rock doesn't stay quiet.
Exactly. Imagine a massive, heavy rainstorm comes over the next few weeks, which represents the child growing up.
The body changing.
Right. The quiet stream swells into a rushing, powerful river. As the volume of water increases, as the child's muscles lengthen, their bones grow heavier, their body weight changes, and their nervous system tries to mature, well, the water hits that rock completely differently now.
Wow. Yeah, it really would.
The rapids and the turbulence around that static rock change violently. The water might crash over it, carve deep erosive channels around it, or alter the entire flow in the riverbank.
Because of the pressure.
Right. The rock didn't change at all, not a single bit, but the river's behavior around it is entirely different.
That analogy highlights the exact mechanism at play perfectly. The abnormal muscle tone and the altered movement patterns that stem from that static rock in the brain, they are constantly interacting with the dynamic, aggressive process of a growing human body.
It's a clash between the static signal and the growing body.
Yes. Let's look at the biology of a growth spurt to really ground this.
Okay.
When a child grows, their bones lengthen rapidly. In a typical child, the muscles stretch and lengthen right alongside the bone.
They grow together.
Right. But a child with spastic cerebral palsy has muscles that are constantly receiving a signal from the brain to stay tight and contracted.
So the signal is saying stay short.
Exactly. So as the leg bones grow rapidly, that tight spastic muscle refuses to stretch fast enough to keep up with the bone.
Oh, I see.
It acts like a tight rubber band pulling against the growing skeletal structure. Eventually, that tension causes a contracture. The joint gets pulled out of alignment or just gets stuck.
And now walking becomes much harder or impossible.
Right. The original brain injury didn't get a millimeter larger. But the physical consequences changed dramatically because the body's scaffolding was forced to grow around that tight rubber band.
The underlying rock is static, but the clinical river is dynamic.
The clinical transcript actually gives us a golden rule to remember here. It says, the underlying lesion is static, but the clinical course is dynamic.
That distinction is incredibly clarifying. But I have to say, it also sounds like a terrifyingly delicate balance for a doctor to strike.
It absolutely is.
Because if the symptoms are getting worse, how does a doctor know if it's just the body growing or if they got the diagnosis wrong?
And that is why this is so critical. If we connect this to the bigger picture of diagnostic accuracy, a misdiagnosis here alters the rest of a patient's life. Clinicians have to watch out for a massive red flag, which is true developmental regression.
What does that look like in practice? True regression.
If a child is clearly losing previously acquired cognitive abilities, like, losing speech they already had, or showing steadily progressive neurological worsening, that is a glaring warning sign.
So it's not just muscles getting tight, it's the brain function slipping.
Exactly. If the brain itself is actively deteriorating, that is not cerebral palsy.
Because in that scenario, to go back to our analogy, the rock itself is actually growing.
Exactly. If the rock is growing, you are looking at something else entirely. Those findings should immediately prompt a doctor to stop, pivot, and look for neurodegenerative diseases, genetic conditions, or metabolic disorders.
That makes total sense.
Cerebral palsy is stable at the source, dynamic in the symptoms. Progressive disorders are worsening at the source. That distinction literally saves lives.
Wow. Okay, so we've established that cerebral palsy is this dynamic, lifelong reality. And because it's so intimately tied to the unique way a specific child's body grows and adapts, well, it's going to look vastly different from person to person.
Oh, incredibly different.
We can't just use one label for everyone.
No, we cannot. The source text repeatedly emphasizes that cerebral palsy is an umbrella term.
Right.
It encompasses highly heterogeneous conditions. We really need a map to navigate the sheer variety of ways it presents, which is why the medical community relies on very specific classification systems.
So what does this all mean for how a doctor actually describes a patient's condition on their medical chart? Like, how do we break down this umbrella?
The first major approach is classifying the condition by the predominant motor abnormality. Basically, what kind of movement problem is dominating the clinical picture?
We touched on these earlier. Spasticity is the most common, making up the vast majority of cases.
Right, that stiffness and resistance to stretching.
Then you have the dyskinetic types dealing with fluctuating muscle tone and involuntary movements, and atactic, which is the balance and coordination issue.
Exactly. But if a patient has spastic cerebral palsy, which again is the most common type, the clinicians have to classify it a step further.
Okay, what's the next step?
We need to describe the topographical distribution of the motor involvement across the body.
Which limbs are actually affected?
Right. And this maps directly back to which specific part of the developing brain sustained the initial injury.
The prefixes used here actually make a lot of logical sense.
They do, yeah.
If the brain disturbance is highly localized and only affects one single limb, say just the right arm, that's monoplegia.
Right. And if the disturbance affects one entire side of the body, the arm and the leg on the same side, which often happens when one specific hemisphere of the brain is injured, that is hemiplegia.
Got it. Then there is diplegia, where mostly both of the lower limbs, the legs, are affected, while the arms might have only very mild involvement.
And if the injury is more diffuse or severe, you might see triplegia affecting 3 limbs.
Or quadriplegia.
Right. Quadriplegia involves all 4 limbs. And actually, quadriplegia often also affects the trunk of the body, the face, and the oromotor muscles used for speaking and swallowing.
Okay, so that gives us a really good map of where the condition is localized on the body and what kind of movement issue it is.
Yes.
Like spastic quadriplegia or dyskinetic hemiplegia.
Exactly.
But, and I'm putting myself in the shoes of a parent hearing this, or a physical therapist preparing for a new patient, knowing someone has spastic quadriplegia tells me where the stiffness is located.
Right.
But it doesn't actually tell me what they can do on a Tuesday morning.
No, it doesn't.
Can they walk to the kitchen to get a glass of water? Do they use a wheelchair full time? Can they sit up unassisted?
And that is the exact communication gap that frustrated the medical community for decades.
I can imagine.
Anatomical labels are great for neurologists, but they don't tell us about functional reality. A physical therapist reading a chart from 5 years ago might see the words severe CP.
But what did the previous doctor consider severe?
Exactly. Did it mean the child couldn't walk, or did it just mean they had a very pronounced limp?
The language was too subjective.
It was. So, to solve this, researchers developed the Gross Motor Function Classification System, universally known as the GMFCS.
The GMFCS.
Yeah.
How does it change the conversation?
It is a 5-level system designed strictly to describe gross motor function and mobility.
So it's purely about movement.
Purely. It doesn't diagnose anything. It doesn't care if the motor subtype is spastic or ataxic, and it doesn't care if it's diplegia or hemiplegia.
It just looks at what they can do.
Right. It strictly looks at the patient's self-initiated movement and what they can actually do in their daily environment.
So it's essentially a spectrum of independence.
Exactly. At level 1, which is the least affected end of the spectrum, individuals can walk independently without mobility devices.
So they might just look like they have a slightly awkward gait.
Yeah, they might have some subtle limitations with balance or struggle with really demanding physical activities like running or jumping, but they're generally mobile on their own in their communities.
And as you move up the numbers, the need for assistance increases.
Correct. By the time you reach level 3, an individual typically needs a handheld mobility device to walk indoors, and they might use wheeled mobility in the community for longer distances.
Like a walker or crutches.
Right. And it scales all the way up to level 5, the most severely affected end. At level 5, individuals require extensive physical assistance and specialized adaptive equipment just to maintain a seated posture.
Oh, wow.
And they rely entirely on wheeled mobility, which is often powered or pushed by a caregiver.
So it essentially creates a standardized objective language. By saying GMFCS level 4, suddenly the neurologist in London, the rehab professional in New York, the researchers running clinical trials, and most importantly, the patients and their families, they are all speaking the exact same dialect.
Yes, the subjective guesswork is completely gone.
Expectations are incredibly clear, and care plans can be perfectly tailored to that specific level of function.
It truly revolutionized patient care because it forced the medical system to focus on the patient's lived functional reality rather than just the anatomical location of their brain injury.
Looking back at our entire deep dive today, it is amazing how thoroughly we've had to dismantle that original, flawed one-liner we started with.
Brain damage at birth causing spasticity.
Right. Cerebral palsy is not just a static state. It is a complex group of permanent, non-progressive disorders that originate in a developing brain.
A developing brain, absolutely.
And while that initial structural disturbance in the command center doesn't worsen, it interacts constantly with a growing, changing body to cause highly dynamic, lifelong functional limitations.
And because those dynamic limitations are so incredibly varied from person to person, we have to rely on precise classifications.
Right, like movement types, body distribution, and functional scales like the GMFCS to truly understand and support each individual patient. Which brings us back to you listening right now.
Yeah.
Whether you're a medical student furiously prepping for an exam and trying to avoid stepping into a diagnostic trap, or you're just someone who wants to be a more informed, empathetic member of society, understanding these nuances changes everything.
It really does.
It completely shifts how you view physical disability.
It demands a shift in perspective.
It moves the focus away from this tragic binary idea of a broken brain that simply can't be fixed. Instead, it asks us to understand and support a deeply dynamic human body that is constantly actively adapting to a unique starting point.
I love that.
The rock in the stream doesn't move, but the river around it is alive, rushing, and constantly carving new paths.
And this raises an important question to leave you with as we wrap up our analysis of these sources.
What's that?
If the original brain injury in cerebral palsy is truly static, but the individual's clinical course changes dynamically purely because their physical body is growing and developing.
The river swelling.
Right. What happens when we stop focusing all our energy on trying to fix the static rock? What if we focus our future technologies, our orthopedic engineering, and our rehabilitative therapies entirely on managing and adapting to that growing body instead? If we can perfectly manage the flow of the river, how much of this lifelong limitation could we completely rewrite?